Hello students, my name is Dr. Ashutosh and I welcome you in one more video of this biomechanics series, which is about the elbow joint general features. Till now we have studied the osteology of elbow joint, and we know that there are two joints in the elbow, which is your humeroulnar joint and humeroradial joint. Also, there is one thing we must know, it is that the humeroulnar joint is responsible for providing the stability at the elbow joint. This is the biggest joint, and that is the reason that more of the stability comes from the humeroulnar joint, not from the humeroradial joint. And we know that humeroulnar joint is formed by the trochlea of the humerus and the trochlear groove of your ulna. So let's start today's lecture. And this is what it is written over here, that most of the structural stability at your elbow joints come from the humeroulnar joint. Now we must understand what is the type of joint. What is the type of elbow joint? It actually resembles like a hinge of the door, which only performs the movement in one plane. But that is not the case with the elbow. It is a modified hinge joint, which means that there are the movements possible at this joint in two planes, but at one plane more movement cannot happen. So what is happening over here is that whenever you are doing the flexion and extension, the movement is occurring at the sagittal plane and around the frontal axis. But also when you are doing the flexion and extension, there are side to side movement which is happening simultaneously, which means the movement is actually occurring in the frontal plane, but this movement is not very great so that we can count it. So this is the reason we cannot call this joint a hinge joint. This is a modified hinge joint because there is side to side movement present whenever you are flexing or extending the elbow joint. Now there is an angle which we all must know, which is present between the humerus bone. This is your humerus bone, and imagine there a line which is parallel to your humerus bone, and there is a line which is parallel to your radius and ulna. So when you combine both of these joints, there is an angle present between these joints. This is the reason your elbow is slightly outward. It is slightly abducted from your normal median axis. If you see my elbow over here, this is slightly abducted. This is abducted because there is an angle present over here. But what is the reason of this angle? Why this angle is over here? This angle is actually also called as a carrying angle, which means that because of this angle you can easily lift anything and carry, and that thing that you are carrying will not actually come and coincide with the body. This is the reason we call this angle the carrying angle. But why this angle is coming out? This is coming because of the disparity between the two lips of the elbow, specifically at the trochlea. When we studied the humerus bone, in trochlea there were two lips, which was your medial lip and lateral lip. Your medial lip was more distal than the lateral lip. That is the reason that your bone is actually, because this medial lip is more distal than the lateral lip, your bone is actually tilted outside. This is why there is angle present over here. So whenever someone will ask you what is the reason of this carrying angle or this cubital valgus, the reason is that at elbow there is trochlea. In trochlea there are two lips, and the medial lip is actually more distal than the lateral lip. That is why to fit properly your actually ulna goes slightly out or in abducted position. This is the reason it is present. It is more in females if you compare it with the male. The reason is that because of the wider pelvis, because there is a wider pelvis in female, so for them to walk freely with carrying the objects, this angle has to be more in order to accommodate this wider pelvis. So this is the reason this carrying angle is more in female than the male. So whenever this angle increases, it is called as cubital valgus, because this fossa is cubital fossa and there is abduction, so this is valgus. Whenever it decreases, this is called as cubital varus. So there can be two conditions, which is cubital valgus or cubital varus. When you will call a joint a cubital valgus or cubital varus, so if the normal carrying angle is about 15 degrees, if it is less than 15 degrees, it is cubital varus, and if it is more than or greater than 15 degrees or around 20 degrees, it will be called as cubital valgus. You must have seen or know about the screening of the army. So whenever someone goes in army there is a musculoskeletal screening in which they check this cubital valgus angle. So if there is cubital valgus more or there is more abduction at the elbow joint, they reject that candidate. I want you all to please find out the answer why army rejects the candidate with cubital valgus. If you get that answer, please comment down in the comment section. Now let's understand the periarticular connective tissue. What are the soft tissue which surrounds the elbow joint, and what are the structures that are providing the stability to this elbow joint? So first is the articular capsule. There is one interesting thing that the articular capsule at the elbow is surrounding three joints. What are those three joints? First is your humeroulnar joint, second is your humeroradial joint, and also your proximal radioulnar joint is surrounded by this articular capsule. So this is what is written in this slide, that articular capsule encloses three articulations, which is your humeroulnar, humeroradial and proximal radioulnar joint. Your articular capsule is getting the reinforcement also. Your articular capsule is getting the reinforcement by the lateral set of the collateral ligament. So there are two sets of the collateral ligaments. One is lateral collateral ligament present on the lateral side, and medial collateral ligament present on the medial side. This articular capsule gets reinforced, get additional stability on outside of the elbow joint by this lateral collateral ligament. Now moving on in understanding the medial collateral ligament first. So there are three bands in the medial collateral ligament. As you can see in this diagram also, this is the anterior bundle, this is the posterior bundle, and then there is a transverse bundle. Let's understand each bundle one by one. So anterior, most abduction force is resisted by this anterior band, and it arises from the anterior part of the medial epicondyle. This is the anterior part of the medial epicondyle, and it gets inserted on the medial part of the coronoid process of the ulna. When we studied the ulna, there were two processes at the ulna. First was your coronoid process and the other one was the olecranon process. So this anterior band of the medial collateral ligament arises from the anterior side of this medial epicondyle, and it gets inserted at this coronoid process, and this is the ligament which is responsible in resisting the abduction forces at your elbow joint. This is a very peculiar and important part of the medial collateral ligament. It is also taught in full extension. Whenever you are doing the full extension, these ligaments get taut. The reason is that because it is present on the anterior side, and whenever you are doing the extension, so the ligaments on the anterior sides get taut because there is the forces, there is a tensile force in the anterior direction when you do the extension. Next part of this medial collateral ligament is the posterior part. So whenever you will be doing the flexion, this ligament will get taut because this is present on the posterior side. So anterior was getting taut in the extension, and your posterior is getting taut in the full flexion of the elbow joint. This is also responsible for the abduction force resistance, and it is coming from the posterior part of the medial epicondyle, and it gets inserted at the medial margin of the olecranon process. So there were two processes at ulna. One was olecranon process, which was on the posterior side. There was a coronoid process on the anterior side. So your medial collateral ligament's anterior part is getting inserted at the coronoid process, and the posterior part is getting inserted at the olecranon process. The difference between these two ligaments is that whenever you are doing the full flexion, your posterior ligament will get taut. Whenever you are doing the extension, your anterior ligament will get taut. The similarity between these two parts is that both the parts will resist the abduction forces at the elbow joint. Also, there is a transverse part. This is not do not responses for the stability. Do not provide the stability at the elbow joint because of its location. So the role is also to prevent the abduction force, but it cannot resist the abduction force. The reason is that it is arising from the olecranon to the coronoid process of the ulna, which means it is arising from the one bone and inserting on the same bone, which means coming from the olecranon process and attaching at the coronoid process and coming from the olecranon process. So this is the reason this do not provide the articular stability at the elbow joint. Now let's understand the lateral collateral ligament. So lateral collateral ligament will be on the lateral side. In lateral collateral ligament there are two parts. First is the radial collateral ligament, which means it will get inserted on, it will be getting inserted on the radius bone. Then there is ulnar collateral ligament, which means that it will be getting inserted at the ulna. So from where they are getting originated? They are getting origination at the lateral epicondyle, then they splits into two parts. One part attached to the annular ligament on the radial head, and the other part attaches to the supinator crest of the ulna, from where your supinator muscle is also arising. So radial collateral ligament goes and attaches to the annular ligament, and your ulnar collateral ligament goes and attaches to the supinator crest, which is also the origin part of the supinator muscle. So here you can see this is the lateral epicondyle, and from here the ligament, lateral collateral ligament is coming and splitting into two parts. This part is the radial collateral ligament because it is on the radius, and this is the ulnar collateral ligament. Okay, this is the proximal part of the ulnar collateral ligament, and this is the distal part of the ulnar collateral ligament. Now let's summarize all these things, that what are the forces that are preventing the valgus force and what are the forces that are preventing the varus force. So what is a valgus force? Whenever there is a abduction force, there is a force in the outward direction, then there is a simple formula that whenever you are pulling it outwards, then this medial collateral ligament will get actually taut. If you are doing the adduction, then the lateral collateral ligament will get taut. In valgus or varus force, medial collateral ligament is getting taut, especially the anterior fibers, also the posterior medial capsule, because it is present on the medial side and on the posterior side. So whatever is present on the medial side during the valgus force, that structure will get taut. Then on the varus force, there is lateral collateral ligament and the posterior lateral capsule. So posterior part, because the arm is in extension position and you are doing the abduction force, and lateral part because the force is in the adduction direction. So also there are some mechanoreceptors which are present in the ligament. So these are those mechanoreceptors: Golgi tendon organs, Ruffini terminals, Pacini corpuscles, and free nerve endings. These are the structures which provide the proprioception capabilities to the joint, and they are also present in the ligament. The clinical relevance of it is that whenever the ligament is getting injured, these mechanoreceptors also get injured. So this is the reason you will see in your patients that their proprioception gets affected, the balance get affected, the ordination, the agility gets affected. These all are the subparts of the proprioception. Why they are getting affected? Because mechanoreceptors are actually affected at those joints because of this energy, because of this injury. These all are embedded in the ligament itself. Then intracapsular air pressure. So whenever you are doing a normal elbow flexion at 70 degrees, this intracapsular air pressure is minimum. This is also known as the resting position for your elbow joint, because the elbow pressure, the pressure within the capsule is minimum. So you will feel the most comfort in keeping your elbow at 70 degrees of the flexion. This is the reason that after trauma, there is a post-traumatic stiffness present at the elbow joint, mostly at 70 degrees. So there is a range which is 70 to 120 degrees in which stiff elbow is seen. Why stiff elbow is seen specifically into this 70 to 120 degrees? Because at this angle the intracapsular pressure is very less. This is the position of the maximum comfort at the elbow joint, and this is the reason you will see most of the contractures or stiffness at elbow joint occurring at this position, because the intra-articular capsular pressure is minimum at these degrees. So this was the research which was done to find out the intra-articular capacity and compliance of stiff and normal elbows, which showed the result that we discussed. Now these are some questions for you. You need to read them and answer them in the comment section. So this is the first question, which is the articulation between the trochlea and humerus and the trochlear notch of the ulna, and which is the primary hinge joint in the elbow. What is this joint called? So you all know what their joint is called. Comment down the answers. Next question is, what type joint is elbow joint? This is a very easy question. I hope that all of you must get the correct answers in the comment section. So this was it for today's lecture. This was very short lecture discussing the general features of the elbow joint. In the next lecture, we will study the radial ulnar joint and their general features and the kinematics. Thank you.